Good evening, and welcome to COVID-19 Vaccines, Truth and Untruth. This town hall meeting where we'll respond to your questions about the COVID-19 vaccines. This event is being co-hosted by the Caribbean Center for Health Systems Research and Development, the Faculty of Medical Sciences, and the Faculty of Social Sciences at the St. Augustine campus of the University of the West Indies, as well as UETV. I am Donald Simeon, Professor of Biostatistics and Research at the Faculty of Medical Sciences and Director of the Caribbean Center for Health Systems Research and Development. With me is a panel of UWI experts who will be answering your questions. They include Dr. Clive Landis, Pro-Vice Chancellor, Professor of Immunology and Chair of the UWI COVID-19 Task Force, Dr. Terence Simongal, Professor of Medicine and Dean of the Faculty of Medical Sciences and member of the UWI COVID-19 Task Force, Dr. Christine Carrington, Professor of Molecular Genetics and Virology, and also member of the UWI COVID-19 Task Force, Dr. Talia Esnat, Sociologist and Head of the Department of Behavioral Sciences at the Faculty of Social Sciences, and Dr. Jeffrey Edwards, Lecturer in Public Health, Faculty of Medical Sciences, UWI St. Augustine. Of course, vaccines have been the flavor of the day, and for good reasons, as they are important for the control of infectious diseases that have a large impact on populations in terms of death and suffering. Indeed, over 3 million persons have died globally from COVID-19 to date, and the number of deaths are increasing in countries such as in India. In the Caribbean, we have had 2,340 deaths up to this morning, with as many as 83 in the last week. This is within CARICOM countries. So COVID-19 is deadly, and importantly, there is no cure for the disease. With this in mind, I would like to introduce Professor Terence Simongal to give his welcome remarks. Professor Simongal, of course, is the Dean of the Faculty of Medical Sciences at the UWI St. Augustine campus. Professor Simongal.
Good afternoon, everyone. Thank you, Donald. So we are here to discuss issues associated with the use of the COVID-19 vaccine here in Trinidad and indeed in the Caribbean. We have had many concerns expressed in the local media about vaccines. We had a conference on vaccines and vaccine delivery a few months ago, and there it came about, we came to understand that there are a lot of queries in the minds of the population, something that we refer to as vaccine hesitancy. The Faculty of Medical Sciences came together with the Faculty of Social Sciences to come up with and to frame a proposal for the Ministry of Health that would assist them in the vaccination campaign that is ongoing. And we realized in doing so that there was a need for a second conference aimed at the population as a whole. And this is where we are today. So I welcome all of you to this meeting, and I certainly hope that you have your questions answered as the evening goes by. Thank you very much.
Thank you very much, Professor Simongal. I now invite Dr. Akala Lewis Cameron, the Dean of the Faculty of Social Sciences, to deliver her remarks.
Good evening to my UWI colleagues, Professor Simongal, Dean of the Faculty of Medical Sciences, Chair of this evening's forum, Professor Simeon, distinguished members of the panel, as well as our viewing audience. I'm so pleased to be part of this most relevant and timely forum as we engage with the issues surrounding the truths and untruths of vaccination. In the Faculty of Social Sciences, our mission is to be socially engaged and solutions-oriented. As such, the Faculty of Social Sciences was very keen to partner with the Faculty of Medical Sciences to contribute to providing accurate responses to the questions asked by many of us concerning COVID-19 vaccinations. I want to particularly thank the team at the Faculty of Social Sciences, specifically from the Department of Behavioral Sciences, who would have committed many hours of research in preparing a comprehensive report on vaccine hesitancy. Thanks goes out to Dr. Talia Esnard, sociologist and head of the Department of Behavioral Sciences, Dr. Christine Descartes, psychologist in the department, Dr. Camille Huggins, and Dr. Sherilyn Boudram, who are both social workers in the Department of Behavioral Sciences. This partnership with the Faculty of Medical Sciences is the first of many more to come. One of the things that this initiative has revealed to us is that there is certainly a need for further research in the area of the sociology of health. As a colleague of mine indicated, it's about bringing medicine to the people in a way that is easily understood. And so we are starting the conversation this evening, and I look forward to the deliberations and discussions that we would have here this afternoon. So colleagues, I want to wish you the very best as we proceed with this evening's proceedings. Thank you.
Thank you very much, Dr. Lewis Cameron, for your welcome remarks. Of course, as the Dean of the Faculty of Social Sciences. I would like to invite Professor Clive Landis, Pro-Vice Chancellor and the Chair of the UWI COVID-19 Task Force. Professor Landis.
Well, thank you very much, Donald, and pleasant good evening to all viewers wherever they are. I'm here in Barbados, recovering from the ash fall. Gives me something else to worry about. But I'm very pleased to be a part of this forum and also to have two of my colleagues from the UE COVID-19 task force here. So our task force, we started off by advising governments with the best possible science about epidemic projections, about what our capacity is in hospitals and intensive care units to deal with the epidemic, and to provide forecasting. And that enabled the governments to take very decisive steps, which actually led to the complete containment of the first wave in the Caribbean. The Caribbean has done exceptionally well, and kudos to all the governments involved. I think we've entered a new phase of the epidemic now, where instead of being on the defensive and trying to stop the virus from spreading, which of course has in the process, despite our public health successes, has led to real economic and social impacts, which are not sustainable. The new phase now sees us on the front foot. And so we're now in the vaccination phase. When you look at some of the best practice countries which have gone before us and achieved high vaccination rates, together with very sort of logical, gradual disassembling of the distancing and social protection protocols, we can now see the way out of this pandemic. So I'm really happy to be here today with my colleagues in order to share with the public about what the path out of this pandemic is, and in so doing to address whatever concerns they may have. Please say whatever is on your mind.
Great. Thank you very much, Professor Landis. To inform our viewers that the town hall meeting is divided into two segments. During the first segment, we'll be playing 4 pre-recorded questions from members of the public. These were recorded at various locations in Trinidad, and the panel will respond to them. During the second session, the panel will be fielding questions from you, the viewing audience. Indeed, the chat facility was open a few days ago, and we have already received quite a few questions, so I look forward to your additional questions this evening. The first video will now be played, and I'll invite Professor Clive Landis to respond to it, please.
My name is Christine. I would like to ask, what does the vaccine have in it?
Okay. Boy, that was a short question. I was just about to take some notes. Christine, vaccines always have the same basic ingredients. It is an instruction for your immune system to fight off a illness, but the components of the vaccine are just copying the illness. So they're not harmful in themselves. And so the vaccines do differ in how they achieve this. The traditional approach has been to take a virus, which either by its own sort of course gradually became harmless. So, for example, the tuberculosis vaccine that's been around for over 100 years, it's called the Bacillus strain of TB. It's harmless, and it's given to you. That's the one where they scratch your arm. And that tells your immune system, well, you want to fight off something that looks like TB. So if you happen to go to a TB endemic country, you will never catch it because your immune system has already been instructed how to fight it off. And some of the vaccines, not those that we've seen in the first wave of vaccines have been quite sophisticated molecular vaccines. But in the next phase, you're going to see the sort of traditional heat kill vaccines, where you just take a virus, grow it, and heat kill it. And so again, it's harmless because it's heat killed or irradiated or chemically treated, but it still trains your immune system to fight off the real thing. But the first ones through the door, and it's no accident that they have been the first ones through the door and they were developed very quickly, are basically using the instructions which were published by the Chinese on January the 9th, 2020, about the spike glycoprotein. Remember, the coronavirus is called corona because it looks a bit like the sun, or a crown, excuse me. And so those spikes coming off the crown, those are the bits that the immune system recognizes. So as soon as the sequence was published on the 9th of January, vaccine manufacturers had all the information they needed to create that little spike protein. That's all they needed. And that is given in various forms. So the very first vaccine to get through the door, it just uses the coding material from messenger RNA, which is the RNA that lives in the cytoplasm. It's very short-lived. It doesn't even enter the nucleus. And that gives the instruction to make that protein. And then the next one through the door, where the so-called empty vector vaccines, where you just take a sort of common cold vaccine that's been disabled, and virus, and then you actually place that spike glycoprotein in it. And then that generates an immune response to the glycoprotein. These are inherently very safe because they contain no infectious or whole virus particles at all. So there are various different approaches, but it's always the same principle. It is using a harmless mimic in order to teach your immune system to fight off the real thing.
Excellent. Thank you very much, Professor Landis, for a very comprehensive response. The second video question will be responded to by Professor Terence Simongal. Can you please play the second video?
Hello, good morning. My name is Donald Mohit. I'm from Kunapia, Chinchin Junction. I'm asking about the side effects of the Astrazeneca vaccine.
I am Showing Noel from the Cooper Market Association, vendor craftsman. What I would like to know from the good doctor here is, how sure are you with this AstraZeneca vaccine, given the little side effect that it has with clot blood and thing, and not only that, the rate at which they prescribe it, when 3 years normally was the given time for certification of a vaccine?
Okay, so I'm going to address the issue of the clots with regard to the vaccine that we have, and then I want to talk about the 3 years that one of you mentioned. So what is the risk of these clots? So first of all, can the vaccine cause clots? I think the research world is coming around to the idea, yes, that it can, because the clots that it causes are so rare and they manifest in such weird and unusual ways that it wasn't at first believable that it was caused by the vaccine. But I think maybe enough data is now accumulated for us to believe that most likely it is. So that's the first point. So yes. Now, how frequent are they? It's been estimated for the vaccine that we had at 4 per million in the UK. 4 per million in the UK. Let's look at other activities that we do that approximate that sort or have risk associated with them. If you get into a motor vehicle in the United States, the risk of death is 119 per million. In Trinidad and Tobago, it's 163 per million. But we all go into our cars, and if we're walking at the side of the road and somebody offers us a lift, we're likely to say yes, if we know them, of course. And what about deaths from COVID-19? In Trinidad, we have a 2.5% death rate, but out of a million, that's 25,000. Remember I said 4 per million is the rate estimated in the UK for clots. Is there anything else that approximates that sort of death rate? Well, if you go in an aeroplane, and a lot of Trinidadians fly to various parts of the world, the death rate is estimated at 5.3 per million. But we go in aeroplanes. So what I'm saying is, yes, there is the possibility of a very rare disorder, but it is just that, very, very rare. And you have to balance the risk of that disorder against the risk of death from COVID-19, which in Trinidad and Tobago, as I said, is at a rate of 2.5%, which is 25,000 per million. If you do get the clots, well, in the UK and in the European Union, they've put websites up that with information on them as to how you can tell. So you have rare pains, unusual pains in the abdomen, difficulty in walking, sudden onset, of course, headaches, chest pains. You go immediately to the nearest emergency center. And it's emerging how it can be treated. So what I'm saying is, yes, there's a possibility of a very rare complication. The individual has to balance the risks. But if you look at the big picture, the risks are clearly balanced in favor of the vaccine, as advised by the public health system in all countries. You mentioned the 3 years. Well, SARS-CoV-2, which is the virus causing COVID-19, is not a new class of virus. We've had coronaviruses around with us for quite some while, but in 2003, there was a SARS-CoV-1, first one that occurred. That one is similar to this one. It's not the same. So scientists have been experimenting with different ways of combating it, so that the idea of vaccine development to this one was not new. MERS is another one that came around 2012, if I recall correctly, and there have been experiments there as well. So the reason that vaccine development was rapid here is not just because we have very good technology available nowadays, but also because there's a history of attempts before that to create vaccines. So I hope I've answered the questions. Thank you very much. Over to Donald.
Yes, thank you very much, Professor Simongal. Just one other quick follow-up questions. Are there other side effects that you're aware of from not only the Astrazeneca, but the other vaccines that some of them already are here in the Caribbean and some will be coming in the Caribbean very soon?
Okay, so the AstraZeneca vaccine is called a vectored vaccine. In other words, as Professor Landis said, you have attenuated or weakened virus that you know, say a common cold virus, in which you put something in so that it can go into the immune system and alert the immune system so that you react to the disease that you want to protect the body against. Some of them just use the spike protein itself, the coding for it, in the form of an RNA particle, which they have encoded. That would be the Pfizer vaccine and the Moderna vaccine. Now, those vaccines, there is also a risk. The risk has not been fully quantified, but there is a strong suspicion that there is a risk of clotting disorders as well. Firstly, and secondly, they very rarely, again, it's very rare. For all of them, it's very rare. But there is also a risk of severe allergic reactions. With regard to the vaccine that we have here in Trinidad and Tobago, that's the Astrazeneca vaccine. The other reactions are all very mild, so a bit of pain around the vaccine site, and you may get flu-like symptoms in 24 to 48 hours. And those don't represent a flu, but what they represent is the immune system becoming activated. Thanks, Donald.
Yes, thank you very much, Professor. The third question will be responded to by Dr. Jeffrey Edwards, lecturer in public health. Can you please play the third question?
My name is Raymond Alexander. And doctor, I want to find out when you take this vaccine, if it will prevent you from getting the COVID, limit the risk. Are you getting the COVID or prevent you from getting the COVID at all?
Okay, thank you, Mr. Alexander, for that very important question. The COVID-19 vaccines produce protection against the disease as a result of the persons developing an immune response to the COVID-19 virus. This immunity builds a person's resistance to fight the virus if exposed. Developing immunity through vaccination means that there's a reduced risk of developing the illness and its complications. The Astrazeneca vaccine is available in Trinidad and Tobago and is a 2-dose vaccine. After the first dose, some immunity develops, but it is the second dose of the vaccine that really boosts the immune response, and immunity gets stronger after the second dose. Hence, a person is considered fully vaccinated about 3 weeks after receiving the second vaccine. Thus, it is very important for a person to get both doses of the vaccine. The clinical trials show that the COVID-19 vaccine will protect people from becoming seriously ill, being hospitalized, or dying from COVID-19. Let me repeat this. The clinical trials show that the COVID-19 vaccine will protect people from becoming seriously ill, being hospitalized, or dying from COVID-19. What we still do not know from the clinical trials is the extent to which the vaccine prevents a person from becoming infected with COVID-19 and the risk of passing on or transmitting the virus to others. So this is a really important part of our understanding about what these vaccines do. Do they only protect persons from becoming ill and possibly ending up being hospitalized? Or do they also protect persons from becoming infected and being able to transmit infection to someone else even if the vaccinated person has no symptoms? So people who are immunized, there may be still a small possibility they may be able to transmit or spread the virus. Therefore, even though persons are vaccinated, we need to continue the public health precautions to reduce the chances of being exposed to the virus or spreading it to others. All right, and we all know these public health measures. Wear a mask over the nose and mouth when out in the public. Physical distancing, so keeping the distance from others at least 6 feet. Wash hands with soap and water or use an alcohol-based hand sanitizer. Stay at home if ill. Cough into a tissue or into the crook of the elbow. Avoid touching your faces. Clean and then sanitize surfaces, for example, tabletops, doorknobs, and cell phones. And do not congregate in large groups. Now, if even a person already had COVID-19 infection, they should be vaccinated. The protection that a person gains from having COVID-19 infection will vary from person to person because everybody has a different immune system. And we also don't know how long natural immunity might last. It is known that natural immunity to the virus reduces over time. So currently, individuals who have been previously infected with COVID-19 are eligible to receive the vaccine. And the Ministry of Health guidelines recommend that people who have had COVID-19 infections are able to get the vaccine 6 months after the infection. So in summary, a person is considered fully vaccinated about 3 weeks after receiving the second dose of the vaccine, and it is very important for a person to get both doses of the vaccine. The COVID-19 vaccine will protect people from becoming seriously ill, being hospitalized, or dying from COVID-19. We do not know the extent to which the vaccine prevents a person from being infected with COVID-19 virus and the risk of passing on or transmitting the virus to others. If a person is vaccinated, they should still practice hand washing, social distancing, and wearing a face mask in public to reduce the transmission of COVID-19. And I just wanted to say that as a healthcare worker, I received my COVID vaccine, my COVID-19 vaccine 2 weeks ago. I got a little pain in the arm, a few aches and pains, and this lasted a day. By the next day, I was able to go to the gym and exercise again. So I would much prefer to get a few aches and pains from the COVID-19 vaccine than becoming very ill and being hospitalized from COVID-19. So I'm actually looking forward to receiving the second dose of the COVID-19 vaccine. Thank you. Hope I answered the question.
Yes, thank you very much, Dr. Edwards. You did address the question most appropriately. Okay, the fourth question of this first segment of the town hall meeting will be responded to by Dr. Talia Esnad. And can you please play the fourth video, please?
My name is Candice Lau. What I'd like to know is the COVID-19 vaccine using nanochips or microtechnology to track or control my movements.
Thank you for that question. In response to the question, I would like to really underscore that this is speaking to a wider issue of information. What we know, what kind of knowledge do we have around the vaccine? And certainly in this particular instant, the information that this person seeks is around the technology that is used to create the vaccine and the potential for tracking the population or persons using those nanochips, as she mentioned. And I really would like to underscore and to remind persons that we need to rethink and sort of reflect on what source of information are we getting to inform our own knowledge and understanding of both the vaccine and the virus itself. And we would like to perhaps just hint and to suggest that we take caution to the kinds of information that we hold on to. In this particular instant, we are working within a context where persons know very little about what the vaccine constitutes. And this certainly emerges in the questions that we had this afternoon on what is in the vaccine. And that's the question that we also hear outside of this particular session this afternoon. But in a context where persons do not know what the vaccine is all about and what the virus is all about, you have the potential here for misinformation. And what is going to happen is where there are pockets of information about technology, about cultural beliefs, about conspiracies that exist out there, those pockets of information will be used to circulate and to perhaps share in response to the answers that are emerging out in the public. And really, I would like the public to juxtapose a situation where we have a context where persons know very little about the vaccine and the virus, and the public sensitization perhaps can be bolstered more. And there's a lack of information and knowledge about what is in the vaccine against another scenario where there's an overloading of information that's coming from other sources. For example, social influencers that are on social media, not within an 8 to 4 when the health professionals and others are working, but throughout the day, 24 hours, 7 days a week. and sharing videos and sharing messages and hinges and particular perceptions and understanding. And in many of these cases, lots of what is being shared are not rooted in science-based evidence. They're not rooted in research, but in speculation and in the grasping of information that is not well understood, but that are being shared with the wider public. And you have movements that add to that challenge. You have movements that promote anti-vaccination. They speak of vaccination freedom, which is the ability to exercise their rights not to take the vaccine. And those movements present convincing sort of arguments against the taking of the vaccine. And you have other cases, for example, where in the political sphere, you have leaders, for example, in the US, and there's a case that many of us would be aware of, where we were told that the vaccine is a Chinese virus. And therefore, those types of statements create many beliefs about the origin of the virus, but more importantly, the agenda behind the virus, and they create lots of suspicion from the public. When that now comes together with people's anxieties, and you have the psychopathological sort of traits among people where there's anxiety and there's depression and there's fear, and that coalesces with a sort of a lack of information and a desire to know more, you have people turning to cultural practices and cultural beliefs when they go back to what a grandmother would have said to them about a particular type of herbal medicine that could be used, garlic. You have burnt orange and all of these other scenarios that are now unfolding, and people are going to turn back to that as a way of finding some sort of answer to a crisis in their mind that must be addressed some way if there's a lack of trust from the pharmaceutical companies, the healthcare professionals, and even the researchers, for example. And what is clear is that we have more than one pandemic on our hand. Yes, we have the COVID-19 pandemic, but we also have, as WHO has reminded us, we also have the infodemic, which is really a crisis in the spread of misinformation that circulates just as fast and perhaps even faster than the vaccine itself. That in itself is a crisis. And it is so very important to address, and I'm happy to hear this afternoon Professor Simangal and others sharing critical information with the public, because it's important to be honest and authentic and truthful and to speak and engage with the public on matters of concern. And this is where the difference can be made in what is perceived as credible information vis-a-vis what is misinformation. And it is really important, and I would like to underscore that there's a conversation between the information that is spreading through social media, through social influencers and other forms, and what is coming out from credible sources like health officials, WHO, and the like. If that is not in place, and we don't have an authentic conversation around those fears, what is going to happen is there'll be a deeper mistrust, a lack of trust for healthcare professionals, doctors and researchers, and pharmaceutical companies. And this would now move us from a situation of vaccine hesitancy to vaccine refusal. And when this happens, and even before that, it is critical for, as a society, that we remind our people and ourselves of the importance of media literacy, of being critical of what we hear, the source of information, of asking questions related to the information that we receive, and seeking information that comes from credible sources, just like what is being offered to everyone this afternoon. Thank you.
Thank you very much, Dr. Esnaz. And you mentioned about the infodemic. I myself am quite concerned about it. And the question is, what can we do? I mean, so perhaps I can ask you a first question. What do you suggest that the average person who is faced with all of this misinformation, I mean, should they just ignore everything that comes their way? I mean, you mentioned about trust, you know, in our health professionals and our credible sources of information. So any suggestions as to what can be done in the short term?
Is that critical media literacy really echoing the need to listen, be critical of, cross-check, question the source of information that we receive, the credibility of the information, but cross-reference that against what's coming out from credible sources and agencies such as WHO, CAFRA, and other agencies that are involved in public health campaigns. And health campaign, health promotion, sensitization is critical in that process. And like I said earlier, if the public is not aware of what is in the vaccine, it means that there's more for us to do as researchers, as social scientists, as medical scientists, as pharmaceutical companies, in really telling the public what they are confronting, what they are taking in their own bodies, so that when they make a decision around taking the vaccine, it's a well-informed one. I think that is absolutely critical.
Thanks very much, Dr. Esnat. So we end the first segment of the town hall meeting, and we go into the second segment where we'll be fielding questions from you, the viewers. And I remind you that you can pose your questions on Facebook Live, on the chat on UWTV, or send questions via WhatsApp, and the number is 272-4UWI 4894. The WhatsApp messaging has been facilitated by Digicel Trinidad and Tobago. As I start the question and answer segment, I will highlight a video that has been making the rounds on social media and has been a source of great concern. I will ask Professor Landis to respond to it, in that we received several questions about it. It was presented as a letter written to the World Health Organization by someone who is supposed to be an expert in virology, and who expressed grave safety concerns about the global rollout of the COVID vaccine, the so-called Doomsday Prophecy by Dr. Gert van den Bosch. I'm hoping that Professor Landis, can respond to that video.
Okay, so I hope you're not going to play the video.
No, we won't. Definitely not.
It is supposed to be a conference about vaccine truths, and we don't want to hear any more vaccine untruths. Okay, well, let's just start with who it is. He's a virologist. He is a virologist called Gert van den Bosch, and he has come up with a sort of doomsday prophecy that the vaccines are going to generate lots of variants of COVID-19, and we're all going to die from them. His prophecy is not published in any peer-reviewed scientific journals. He doesn't have any publications in any peer-reviewed scientific journals. He publishes in what are called pay-to-publish pseudoscience journals. So the fact that he goes around claiming to be a worldwide expert is not supported by the facts. His doomsday prophecy is amplified. The picture that you showed there was Del Bigtree, who some people call king of the anti-vaxxers. And his program, Highwire, if you want to know all the latest conspiracy theories, you go to Highwire and they're all there. So, whether it's COVID is actually transmitted by 5G towers, or whether it's COVID, has microchips that are going to control people, or COVID, will give you the mark of the beast, or, whatever it is, it's all there. And please note, they can't all be true. So his basic thesis is that the vaccines are not blocking onward transmission, and therefore they're stimulating the variants to reproduce. So the variants are simply produced when lots of virus is replicating, because the replication process is has an error rate in it, and that produces variants. So the more virus replications there are in a country or in the world, the more likely it is that there are going to be variants. And research has very clearly shown that the worst situation is to have someone who is on ICU for a long, long time, very, very gravely ill with a suppressed immune response. And persons like that will be generating variants within them. Now, the vaccine, of course, prevents people from ending up in hospital. Like Jeffrey said, the one piece of data that has never been shaken by any of the variants is that this stops you from ending up in hospital and dying. And so when you look at the favorite variants, like the UK variant, the South African variant, and the Brazilian variant, the Astrazeneca vaccine that we have here, the trials, by random chance, were done in those 3 countries. And there were no hospitalizations leading to severe illness, leading to hospitalizations and death in that phase 3 clinical trial. Now we've moved way beyond those big trials, which were 30,000 people odd, which established the safety and had the vaccines licensed. Now we're in real world, so let's say the UK, which has used AstraZeneca. The UK is the best example for us because it's used AstraZeneca. So we should study it closely. That's the backbone of the response. They've also used Pfizer, and in fact, they compare the two. But most of the vaccinations have been with AstraZeneca. So in the UK, a very big serology study, which looks at this issue that Gert van den Bosch is worried about, hundreds of thousands of people who've had close serology done, has shown that after 1 shot of either the Pfizer or the AstraZeneca, the results are almost identical. You get about a 2/3 block of asymptomatic. That's the one that could potentially still transmit. Now, remember, the one thing that's never shaken is that you don't die from it. But the worry is, it's a bit leaky, might still transmit. After the second shot, that data was only available up to now because the Pfizer was the first one to go through the gate. It's available for Pfizer that rises to 80%. Now, when you look at this effectiveness in the UK, remember where we started a few months ago? Barely 3 months ago? In the middle of January, 1,200 deaths every day from COVID in the UK. The UK has now vaccinated close to 70% of the adult population. Guess what? We're now down to less than 10 deaths a day in the UK. Think about that. The vaccines have dropped the deaths in the UK from 1,200 to 10. Almost 40% of all hospitals in the UK have no COVID cases in their ICU. So, Dr. Van Bosch, please tell me, how is the vaccine causing the world to end up in a doomsday scenario? Looks to me as if it's doing exactly what it says on the box, which is that it's actually leading us out of this pandemic. And so there is absolutely no foundation whatsoever to what he says. And the real world data coming out of the UK, US, and Israel, which are far ahead in their vaccination program, it gives us the roadmap out of this nightmare, this recurring nightmare that we're in. And as you notice in the UK, very gradual, rational breaking down of the protocols. You can't just rush out like was done in Chile. After you've had your vaccines, you do it very gradually. And then you get these wonderful results. You just work your way out of this pandemic. Let's follow that example and not get sidetracked by the likes of Del Bigtree and Highwire and all of these crazy conspiracies. I actually get quite upset when people pay so much attention to the conspiracies. They should actually be looking at the news and seeing what's going on in India. It's an indulgence to talk about these conspiracies, when thousands of people are dying every day from COVID. I think we really need to stop this.
Thank you very much for that response. And of course, you have really hit the nail on the head that these conspiracy theories are causing so much more damage, than any good whatsoever. Okay, I move on to the next question in this segment. And actually, there has been a number of questions on a similar theme. I'm seeing questions that come in from someone via WhatsApp whose phone number ends with 5167, another person whose phone number ends with 7615, email from Adrian A, email from Francis O, and among others. And what they are talking about is they are inviting the panel, or they're asking the panel to speak about, I'm going to ask Dr. Edwards, and then Professor Simangal can perhaps also add, but they would like the panel to speak about the underlying health conditions that the public should be aware of in relation to taking the Astrazeneca vaccine and other vaccines, and really to know who should or who should not be taking the vaccines. And of course, they are referring to conditions such as asthma, pulmonary embolism, food allergies, allergies to penicillin, immunosuppressed conditions like Gillian-Barré syndrome, etc., HIV, etc. So, so Dr. Edwards, can you please respond to who should not take the vaccine based on their pre-existing chronic conditions?
Okay, thanks, Professor Simeon. According to the Ministry of Health guidelines, the persons who should not take the AstraZeneca vaccine are pregnant women, women who are breastfeeding, and children under the age of 18. And any person who would have a severe allergic reaction to any component of the vaccine. The vaccine is considered safe in most of the conditions. So, I mean, we recommend the vaccine for people with chronic non-communicable diseases, for example, heart disease, hypertension, diabetes, if they're immunosuppressed for any reason. So I've known about 20 HIV patients who also had diabetes or heart disease, and they've taken the vaccine and they've done very well with it. They mentioned things like Gillian-Barré syndrome. There were reports where sometimes persons may get Gillian-Barré or Gillian-Barré syndrome, which is a weakness of the limbs and a weakness of the body, may be associated with a vaccine, which is a very, very rare side effect. It is recommended, most of the experts recommend that if even somebody has Gillian-Barré, what you need to do is to discuss with your healthcare provider the risks and the benefits. So, I mean, as Professor Simangal mentioned, the risks the benefits far outweigh the risks in terms of getting the vaccine. So, I mean, as I said, I took the vaccine. You don't want to end up ill in hospital, being on a ventilator, or dying from COVID. So I would recommend that, I mean, most people, as I said, could get a vaccine. If anybody has any doubt, you can discuss this issue with your primary healthcare provider, your general practitioner, and then you all discuss the benefits and the risks. And as I said, the benefits outweigh the risks. So I would recommend the vaccine for most people, except as the Ministry of Health guidelines say, the people not recommended for the vaccines are pregnant women, women who are breastfeeding, children under the age of 18, and anybody who had a severe allergic reaction to the vaccine. Thank you.
Yes, thank you, Dr. Edwards. Professor Simangoli, would you like to add anything to Dr. Edwards' response?
Well, first of all, I agree with that. And just to add maybe question, immunocompromised persons are definitely at a higher risk for severe COVID-19. Available data are currently insufficient to assess vaccine efficacy or vaccine-associated risks in severely immunocompromised persons, including those receiving immunosuppressant therapy. It is possible that the immune response to the vaccine may be reduced, which will, of course, lower the clinical effectiveness in such people. In the interim, given that the vaccine is non-replicating, immunocompromised persons who are part of a group recommended for vaccination, over 60s or whatever, may be vaccinated. Obviously, they will have to discuss it with their healthcare professional or healthcare advisor, as the case might be. The question of clots is an interesting one. WHO WHO, as far as I can discern from their advice on the internet, would seem to be suggesting that even if there's a history of clots, people should still have the vaccine. It's just that the potential for clots after the vaccine is so rare that it's very difficult to find any correlations that would help us to determine which patients are more at risk as yet. So that's where we are, and it's an evolving area, that particular part. Thanks very much.
Yeah, thanks very much, Professor Simongal, and of course, Dr. Edwards. Okay, the next group of questions relate to possible transmission of the virus to others after vaccination and or after contracting the virus. And I would like Professor Carrington to address these questions. So the question, I'm going to read the question now. After being fully vaccinated, in addition to being less likely to get the virus, how much less likely am I to pass the virus from one person to another? Is there a known % transmission rate post-vaccination? Another question in that same group is, can someone who has taken the vaccine and show flu-like symptoms spread the virus to others on the basis of their vaccination? And the third question in this group is, will someone test positive for COVID after taking the vaccine and had tested negative before taking the vaccine? So, Professor Carrington.
Okay, thank you so much. So there's a lot of questions there. So thanks once again for having me on, and I'll try and get them all in the right order. So the first one was about the likelihood of contracting the virus if you've been vaccinated, and also the likelihood of transmitting it to someone else after you've been vaccinated. So all of these vaccines that we have, I mean, all the vaccines that have been made and the Astrazeneca vaccine, they will protect you against infection, but they don't do so 100%, okay? So there's a difference between being infected with a virus and actually showing symptoms of disease and suffering from a disease. So it is possible to be infected, all right? So the virus gets into your body, but the virus does not replicate and sort of to the extent where you're actually suffering from the disease. So there's a difference between SARS-CoV-2, the virus, and COVID-19, the disease. All of the vaccines will reduce your chance of getting disease, okay? So they reduce it by about between almost 60% and 95% and things like that, depending on the vaccine. With AstraZeneca, it's when you have 2 doses, it's about approaching 70%, all right? So that's the chance of getting disease. In terms of actually being infected, initially they weren't sure whether the vaccine, the immune response to the vaccine would prevent infection altogether, a little bit, or not at all. And what we're finding now is that the vaccine blocks infection and by about 60, almost 70%. So the chance of being infected, of actually having the virus take hold in your body, is dramatically reduced in people who are vaccinated. Now, in order to infect someone else, the virus has to be replicating inside of you. So the less virus there is inside of you, the less chance of transmission to someone else. So the fact that these viruses are blocking infection in 70% of cases, and even in those people who have who do get infection, the evidence is suggesting that the level of virus is much lower. The chance of transmission is also lower. And there have been studies now, and I think Professor Landis could probably chip in afterwards, that have shown that the AstraZeneca vaccine has cut the transmission rate, so the rate of transmission from one person to the other, by about 67%, okay? What I want to emphasize, though, before moving on from this, is the fact that all of the vaccines protect over 90% 100% in most cases against severe disease, hospitalization, and death. So there's a big difference, as I said, between being infected with a virus, showing symptoms, having severe symptoms, having to be hospitalized from those symptoms, and dying from those symptoms. So the vaccines are protecting everyone who's vaccinated against all the severe manifestations. And it's bringing down the rate of infection, bringing down the rate of transmission. So they're working exceptionally well. If somebody who is vaccinated happens to get infected, and as I said, there's a small chance that you can still get infected, then yes, you may be able to transmit it to someone else. This is why they say you should wear your mask after vaccination, continue to wear it until enough people are vaccinated. But the chance of that transmission occurring is much reduced. So there are different types of tests to determine if somebody has been infected by SARS-CoV-2. Some of them detect the virus's genetic material, some of them detect the virus's proteins, and some of them detect the antibodies that you've made against those proteins. When you are immunized with a vaccine, the immune response that you produce can be similar to what you would have if you get infected by the virus. So if you look for antibodies against the virus, you look for evidence of an immune response against the virus in someone who's vaccinated, you can find it. However, things like the PCR test and what we call the antigen test, they look for the PCR test looks for the genetic material, which although some of the vaccines contain it, it doesn't last very long, so you wouldn't expect the person to be positive. And also it targets different variety of parts of the vaccine, of the virus, so you wouldn't expect that. And in terms of detecting antigen, if you looked for the spike protein soon after infection, vaccination, you would expect to find it, but soon that would disappear as well. All you would be left with is the actual immune response. Thank you. Right, so Dr. Simeon he's lost him for a little while, so I've been asked to take over as moderator. So I'll just pull up one of the other questions that we've had, and I'll put this one out to Professor Simongal. In this case, they've asked about, the person's asking, is empirical data from local, regional, or international sources being gathered or monitored in order to advise persons or the immune-suppressed community on the effects of the vaccine on their condition? You touched on the immunosuppressed a little while ago. Perhaps you can follow up with this. Thank you.
Yeah, so data is being collected, but we don't have enough yet out to be able to tell people. Certainly nothing has been published. I expect that with the large studies coming out of England and the work having been done in Israel, that we will get data published soon to guide us on that. Thank you.
Thank you so much. Professor Landis, I'm going to come to you now. There was a question about how long, there's quite a few questions about how long the effects of the vaccine last. So we have one person who's asking, will this vaccination be an annual affair like the flu vaccine has recommended to date? Another question, after the second vaccine, how long will it last in one system? And then we have someone else who's saying that they had their first shot in April, and this next one is scheduled for May 26th, and they're concerned that about the time between those two shots, and want to know what your thoughts are about the duration of the effect of the vaccine. So, Professor Landis?
Okay, good. So these are all good questions. The vaccine, we will only know how long it lasts once we see how long it lasts. We've only started in December of last year. We can make some good guesses, though. So coronaviruses have a set mutation rate. So these variants that we're seeing are totally expected, and they're cropping up at about the rate that we expect. Because remember, these coronaviruses are animal viruses, and they've been in animals for years, and we've studied them for years, and the mutation rate is exactly the same in humans now as it was in animals. So the best guess that most scientists are coming up with is that this will be better than the flu. We don't think it's going to be an annual thing. We think it will last maybe 2 or 3 years, and then you may need to get a booster shot. And for the elderly who would normally get booster shots anyway with the flu, we'll probably start bundling those in with the flu vaccine. And then, if eventually a variant arrives which, does skirt past the vaccine, then, you would switch it out just like you do for the flu. Same principle. It's not a big drama. And you just switch out the vaccine for one which recognizes the most recent variant. So that's about how long does the vaccine last. And then I think the second question was a slightly different one. It was, how long does the vaccine actually last in your body? Well, all these sort of symptoms of the immune response that you're getting, those actually outlast the vaccine itself. The vaccine is in your system, for a matter of hours, hours to days, certainly nothing longer than that. And then, it does its job, it stimulates your immune response, and then it's gone. I do want to emphasize this point, particularly for the mRNA vaccine, which some people are confusing with the behavior of some viruses, which can integrate into your DNA. So there is a well-known virus, HIV, of course, which can integrate into your DNA. The only way it can do that is that the virus itself carries with it a set of enzymes which are totally unique. So reverse transcriptase is one of them. It reverse transcribes the RNA into DNA, and then it has an integrase which then integrates it into the DNA. So that can cause, cancers like Kaposi's sarcoma, for example. And so that HIV family, HIV 1, 2, and 3, can do that. But mRNA cannot. It doesn't even get into your nucleus, let alone integrate into your DNA. In fact, they're very, very short-lived. I think a lot of scientists were quite surprised at how effective the vaccines were because it's so short-lived. The reason it's transported at minus 80 degrees is that, it's a very labile entity, and it likes to sort of just degrade into its, component nucleotides and just sort of dissipate. So it gets in there, and within a few hours, it does what it needs to do, stimulates the immune system, and you're good to go. Yes, I was a bit concerned about the spacing that the person mentioned. If they had their first shot in April, they should only be getting their second shot at the earliest in 2 months later, which would be May. And so ideally, your second shot is between 8 and 12 weeks. This is for the Astrazeneca vaccine, which is what we have here. It's slightly different for the Pfizer. It's a shorter interval for the Pfizer, but the AstraZeneca is very, very clear. It's at its most effective, between 8 to 12 weeks, and then possibly later. But the indication from the company is 8 to 12 weeks.
Okay, thanks very much, Professor Landis, and of course, Professor Carrington. The next question I'm going to be reading now. Why do some people have no side effects while others have lingering side effects? What causes this? There's another related question as to why are some side effects only present in younger persons? I'm not sure if perhaps Professor Landis can answer this again, or perhaps Professor Carrington.
Sure. Well, I'm the immunologist. I should really answer this. So the question is, why do people show different side effects? So people have different immune responses. Let's say that someone, scratches their hand or their leg. Some people just have a more, effusive reaction, and that's just sort of inherent in the person. But the age factor is quite interesting because younger people have more active, healthier immune systems than older people. Ultimately, we die, because our immune system breaks down, we keep getting ill and things like that. There are other reasons why we die, but certainly, the immune system is stronger in young people. So I always tell particularly young people who have quite a sort of vigorous reaction, maybe they have fevers and chills and aches and pains and maybe nausea, I would say you should be very proud of your immune system. It's working really well.
Great. Thanks very much, Professor Landis. Next question is for Dr. Edwards, Dr. Jeffrey Edwards. Our personal physician has advised us not to vaccinate, that neither she nor her parents have been vaccinated to this point. However, we plan to get it eventually. What is your opinion?
In terms of vaccines, as I indicated, we have been doing vaccines in the Caribbean for years. As a matter of fact, we grew up with vaccines. To get into primary schools, everybody must be vaccinated. I would recommend everybody we start the COVID vaccines on a phase basis. So we started off with the healthcare workers, the frontline workers, and the persons over 60 with comorbidities. And I would recommend everybody to take the vaccine, because as I mentioned, you may get a few little aches and pains, lasting a day or two from the vaccine. But I mean, if you get COVID, actually get very ill, end up in hospital, and die from COVID. So I would recommend everybody to take the vaccine once their turn comes around to take it.
Thanks, Dr. Edwards. Of course, that also raises the issue of the advice that persons are getting from their healthcare providers. That Dr. Esnat had flagged that before, trusted sources, and in this case, the person's doctor said that she wasn't taking it or giving it to any of her relatives. So they advised the person not to take it. So of course, that would happen because some persons are not convinced about the vaccines as yet. So I guess that is an issue that we should surely, keep in mind. I'm not sure if anyone would like to add to that response. It is quite, a troubling issue.
I would
Yes.
like to add to it.
Yes.
Okay, so research has shown that, by and large, in a population, you will get 10% of people who are against vaccination, and they're really firmly against. They're, if you want to call them anti-vaxxers. Then you have about 60% of the population who are fine. They take vaccines, have no concerns. And then you have about 30% who are looking for answers. They're looking for more information. Now, where are they getting their information from? The 60%, which includes people like me, everyone on this panel, we tend to be a little bit disengaged. We're like, well, it's no problem. And so on social media, and this research on social media has shown that the 10% who are anti-vaxxers are very active, and they're fully entangled with the 30% who are genuinely looking for answers. And so healthcare professionals in particular, and practitioners like us right here, we have to get more involved in the discussion, because otherwise it will get skewed by people who have sort of these anti-vaccine views. And so I presume that the healthcare practitioner in this particular case is someone who's looking for answers, waiting for answers or evidence or whatever, and is entangled with this whole anti-vaccine movement.
Okay, great. Thanks very much, Professor Landis. The next question is, will taking the vaccine affect my body's natural immunity and ability to fight other viruses? I guess that's you again, Professor Landis.
No, absolutely not. So, there is a sort of, I don't really know how to say it, some sort of a health and wellness fad that's going around natural immunity. I mean, I'm an immunologist. I'm a huge believer in immunity. And there are things that you can do to strengthen your immune system, COVID or no COVID. One, most important, sleep. Sleep is a hugely important determinant of the strength of your immune system. So, get good, solid rest. Secondly, you want to eat exactly the same dietary guidelines that we're familiar with for a healthy heart will give you a healthy immune system. So, lots of fruits and vegetables. And then you consume alcohol in moderation. You don't abuse alcohol or drugs. And then, of course, stress. If you manage stress and you're coping with stress, that's actually okay. That goes through a different pathway known as the opiate pathway. The uncontrollable stress, which is through the adrenocorticotropic ACTH pathway, that's very, very damaging and will damage your immune system. So sleep, healthy eating, and not too much stress. And looking at all these social media posts, about the end of the world is definitely adding to the stress.
Okay, thank you, Professor Landis. A question from UETV website that just came in. How effective is the vaccine in fighting the varying new strains that are suddenly appearing? Perhaps Professor Carrington?
Yes, thanks. So before I answer that, let me just explain again what a variant is. So we have this virus that has been circulating, moving from one person to another. When the virus enters someone's body, it goes into their cells and it basically replicates inside their cells and produces millions and millions of copies of itself. And that spreads from one cell to the next, tissue to tissue, and then out to someone else. Now, during that process of replication, you can get errors being made. And those errors are what we call mutations, okay? Now, the vast majority of mutations have absolutely no effect on the virus's properties, but occasionally you do get mutations that can change the virus's properties. And that's what we're seeing in these variants that people are talking about. Now, so there's a whole variety of slightly different versions of this SARS-CoV-2 virus, and some of them are of concern. These are these variants of concern. And in a couple of them, or some of them, I should say, one of the things that happens is that the proteins on the outside of the virus, in particular the spike protein that Professor Landis spoke about, that protein is slightly different from the original virus. Now, when these vaccines were developed, they were developed with the original spike protein in mind. So the immune response that they elicit is sort of perfectly matched to the original virus. And with the variants now, you might have a slight mismatch, okay? This sort of response that you get. And because of that, what we are seeing is that some of the vaccines have a lower efficacy against the variants. Not all of them. So for example, the one that was first identified in the UK, that one, there's very, very little impact on the efficacy of the vaccines. However, for the one that was first identified in Brazil and the one that was first identified in South Africa, the latter we don't have in Trinidad and Tobago, those ones, you do get a sort of drop-off in efficacy. But it's important to note that that drop-off applies to to mild and moderate disease. So it's not so good at protecting against mild and moderate disease, but it is excellent, continues to be good at protecting against severe disease, hospitalization, and death. Okay, so the vaccines work well against, they work not as well in terms of protecting against all manifestations of infection, but they work extremely well at keeping people away from severe disease, out of hospital, and from dying. Okay, thank you.
Yes, thanks, Professor Carrington. A follow-up question that came from WhatsApp. The last 4 digits of their number is 6238. Is there any danger to a population if it is not known how many people are infected with the different dangerous strains of the virus?
So the SARS-CoV-2 virus is a dangerous virus, okay? So regardless of which strain it is, you get severe disease, you get people end up in hospital for long times, and you have death, okay? Of the 3 major variants of concern that we've seen, one of them, the UK variant, seems to be associated with more severe disease, okay? But the main issue with that particular one is that it spreads much more quickly, okay? So that's one thing. The other 2 variants that we are most concerned about, the one first identified in South Africa and the one first identified in Brazil, those 2 The South African one doesn't appear to cause more severe disease, and the one from Brazil, there appears to be some effect, but it's still not clear to what extent. Okay, so the take home here, the main point is any variant of SARS-CoV-2 can cause severe disease, hospitalization, and death. There's some variants that seem to be associated with it more. Now, in terms of knowing how many people have, who has what variant, I think this is more of at this stage, it's more of a public health question. So it's an important set of information from a public health level, because the interventions that you use can be impacted by the dominant type of variant you have circulating. So for example, in the UK, what they found when the UK variant first emerged was that in parts of the country where that variant was present, the same public health interventions that they had been using before, the same restrictions, were not working as well in that part of the country. And that's because the virus was more transmissible. Okay, so it's important to know. In terms of the other ones which affect the vaccines, or affect they also affect some sorts of therapies that you might lose, monoclonal antibody therapies. You would want to know about their presence so that you can keep an eye on how well the vaccine is working, whether eventually we may have to, change these vaccines to suit the dominant variants and stuff. So we want to keep an eye on that from a public health perspective. From the point of knowing every single person, I don't think that is important. What we need to know is broadly what percent have, at what level do we have what's the percentage for the different variants? What's their prevalence basically, and how is that changing over time? I think the only time you really want to know about a particular variant in a particular individual is if you're going to treat them with like monoclonal antibodies or something like that, and you want to be sure that it's going to work. So that's what I would say. It's very important, but you don't have to know every single person in the country who has a particular variant.
Excellent. Thanks, Professor Carrington. The next question is for Professor Simongol. It's from Facebook, from Shivani R. Countries have asked for persons under 55 to not take the Astrazeneca vaccine and instead take an alternative. Seeing that the highest prevalence of blood clots occur in patients under the age of 30, why is it then that we are still asking younger population to take this vaccine? Professor Simongol?
Okay, so that is an area that is also evolving. In the UK, the latest guidelines that I saw actually mention below the age of 30 to consider an alternative vaccine. So in our case, of course, we don't have a choice of different vaccines. We just have one vaccine. But we haven't reached the people who are under 30, except, and in fact, in the UK, the exception is people in highly pressed services who need to be vaccinated, in which case they say, go ahead and take it. So here where, Shivani, where people have been in the essential services, they have been given the vaccine. So I think more stringent evidence-based guidelines will come out in the next few months, I would expect, as we get more experience with the vaccines. But experience, as Professor Landis said, is evolving because the first vaccine wasn't given in the general population until I think it was late last year, early this year. Just one point, Donald, if you'll indulge me, that I want to add to what my colleague Professor Landis said just now with regard to the immune system and the effects of sleep, which is so important. Boosting the immune system, also regular exercise. But we have to remind people who are in gyms that when they are regular and moderate exercise, very, very important in building the immune system. Lots of data out on that in the last 5 years. But we have to remind people that when they're doing that, in the gyms especially, they must be socially distanced and to wear their masks or some sort of apparatus that would decrease the transmission of the virus. Thank you.
Yes, thank you. The next question is perhaps for Professor Landis again. other countries are having their second and third waves of COVID-19, but not China. Is there a better management of the COVID, or are their vaccines more effective?
Well, the vaccine which has been published, their efficacy has been published, is very similar to the Astrazeneca vaccine, very similar to the Sputnik vaccine. That's CanSino, which is an adenoviral-based vaccine. So it seems to be very, very similar. The coronavac vaccine is a heat-killed vaccine, and that one definitely requires the 2 shots before it gets really up to speed. The vaccines are not better in China, they're not worse. They're basically all these alternatives. The spike glycoprotein is very immunogenic. It's generated beautiful vaccines. So, the protein-based vaccines like Novavax is very exciting. And I'm really looking forward to the Cuban one, which again is similar to Novavax. It's a pure protein. They're all effective. So there's no difference there. Well, in China, clearly you have a different society, and it's a society which is much more used to collective action rather than individual actions or freedoms. And so, the measures that the state can take are just that much more comprehensive. But China is not in some way unique. You look at countries like South Korea, Vietnam, Singapore, they've all managed the virus very well, and in most cases have managed to keep their economies open. So there's no sort of particular magic coming from China. All of those countries, this is really important, all of those countries had a dry run, and they knew what to do right from the word go, because all of them had original COVID, which was called SARS in 2003. I'm very disappointed, I guess. I don't know if Jeffrey is as a public health expert. In theory, you know everything that needed to be done because it was all worked out in China, in Singapore, in South Korea, in Japan, where they had SARS. And in practice, all the Asian countries knew what to do and the Western countries didn't. But we should have known. And so, I think there's some real lessons about future pandemics and resilience. We're going to be getting more pandemics. Just look at what's happened in the last few years. Here in the Caribbean, 2009, the so-called swine flu, AH1N1, 2013, chikungunya, 2014 and 2015, Ebola. Thankfully, that never even reached us, but boy, did it give us a scare. 2016, Zika, and now 2020, COVID-2, SARS-CoV-2. So, we have to expect more of these pandemics, and we really need to learn about how to handle them. And, I want to go back to what I said right at the beginning. The Caribbean has done a really good job. If you look at the deaths per million, so that's normalized per capita, so you can compare small countries with big countries and even whole regions. When you look at the death rate in North America, the cumulative deaths per million, and you look at the cumulative deaths per million in South America, those are both 10 times higher than in the Caribbean. The Caribbean has done an excellent job in maintaining good public health. And the CARICOM in particular, very coherent response, I think it deserves a lot of praise. The difficulty, of course, is that our economic impact is one of the worst in the world because tourism, which has been utterly disrupted, has gone out the window. So public health has been really very strong here, and the economic and social impact has just been devastating.
Okay, thanks very much. The whole concept of COVID fatigue, the response of persons to the lockdown, there's a question about that. I'm not sure if Dr. Esnad would like to respond to, what can be done. People are fed up with the lockdown and all the restrictions. I mean, what can we do?
Thank you, Professor. I mean, this is a question that I hear all too often. Persons who speak of the impact of their own psyche, just being at home with the very people that you live with and you have a very civil sort of engagement with, but in a circumstance like this where there's no outlet, then there's very little and reduced options for expressing frustration, for doing things differently, and for giving persons outlets that they typically get when they're out of the home and they have other options. So we are quite aware that there are social and psychological effects that are continuing with the COVID-19 pandemic, and we hear a lot more recently from medical healthcare providers that the fear of a mental health crisis to follow that of the pandemic. And this is very real, and it's unfolding in ways that we see it happening to many persons, including our young persons who are very much impacted by this pandemic in ways that they are yet to find effective coping mechanisms to address the way in which they feel very much guarded in their own engagement with their friends and with persons outside of the home. So these are very real concerns that we really have to tease out more, not just with healthcare professionals, but certainly with our mental health workers and other social support, social workers who are there to really partner together with these sort of workers to really unpack some of the challenges that are there before us and to find some workable solutions to supporting those who are in need. We need healing, and that's clear. It's not just healing from a pandemic like this, but from the social, psychological, emotional effects that it has been unleashing over the past couple of months. And certainly fatigue may be an understatement. It may be more than fatigue. It may be more than frustration. And it could be an utter mental crisis that is to follow. And if that is the case, we have to also be mindful, not just of the vaccine and using the vaccine as a response to this crisis, but also really treating with and dealing with the mental health and the level of social interactions that our young persons and others in the population have access to, because that would be a crisis that would definitely follow and for which we would have to address going forward.
Okay, thanks very much, Dr. Esnad. Before we wrap up, because it's now 7:30 in the Eastern Caribbean, I have one last question. I think it's for Professor Landis from UETV. Which vaccine is the safest?
Good question. The vaccines are all safe and effective, and they've all been approved for use by all of the major regulatory agencies. So the ones which have been approved, we can trust all of them for being safe and effective. So, if I had to sort of maybe tease out some slightly different side effects, the extreme allergic reaction seems to be a little bit more prevalent in the Pfizer and Moderna vaccines, whereas these rare blood clots, although they're also seen with the other vaccines, even rarer, would be seen in the Astrazeneca vaccine. All of these side effects are extremely rare, and they shouldn't stop people from taking them at all. I also wanted maybe just to end on a slightly personal note. Someone said, whether you can take this if you've had GBS. Well, my mother had GBS, nearly killed her. But she took the vaccine. It's perfectly okay to take. There are very, very few contraindications to taking the vaccines, and I do recommend it for everyone. And, I would say don't try to sort of game the system. All the vaccines are very safe and effective. If you trust the regulatory agencies and listen to those as a trusted source of information, so starting from home, CARPHA, the Caribbean Public Health Agency, is very, very clear, follows all the best advice from the WHO and the major regulatory systems like the FDA and the European Medicines Agency and the UK Medicines Products Regulatory Agency. So, they have all come down on one side, which is that these vaccines are very safe and effective. I probably should end on the Astrazeneca vaccine, because that's the one that we have here. So the real world data that was published last week in the BMJ showed that there wasn't a cigarette paper that you could fit between the Pfizer and the Astrazeneca vaccine for efficacy. They were equally good in the real world setting. So, please don't take on this idea that it's in some way a second-rate vaccine. I think, maybe the company, in being sort of ethical and saying that they would not make a profit on this vaccine. So, it costs about $2 a shot compared to sort of $30, $40, $50 a shot from the other vaccine makers. People were saying, well, maybe it's not such a good vaccine. It's so cheap. But that's because the company said, we're not going to make money off it. This is meant to be to vaccinate the world. And so, I think they have behaved very ethically. And I think it's been very unfortunate how, people have been put off from this very good vaccine. You only have to look at the UK to see what's happening. The hospitals, can you imagine that? Almost half of all hospitals having no COVID cases in their ICUs. And that was down from just 3 months ago from having 1,200 deaths every day. That's the power of vaccines.
Okay, thanks, Prof. I was just informed that UETV said that we can go on for a few more minutes, so I will just take a couple more questions. From UETV, I received my flu vaccine in December. Is it safe to take the COVID vaccine now? I guess that's Prof. Landis again.
Next question.
Sorry, I'm not sure if you heard the question.
Yes, it's safe.
Thanks for that. Okay, the next question that I'm seeing, well, I guess, is it safe to take the vaccine if one has venous disease? Prof. Simongal?
Yes, of course it's safe. By venous disease, I suppose they're talking about varicose veins. Yeah, that's not a problem. Those are in the superficial, the venous system that's closer to the skin. No harm there. Thank you.
Okay, another question from UETV is, are you saying that as medical professionals, you are unreservedly convinced that there is no nanochip in the virus to track persons and it did not originate from China? I'm not sure who would like to answer that.
Goodness. Yes, unequivocally.
Unequivocally. There's no chip.
Yes, there's no chip and it did not, it did originate in China. It was first found there.
Mm-hmm.
So
well, the virus or the vaccine?
No, the virus, I guess.
Well, the virus was first detected in China. The outbreak first occurred in China, but whether it originated in China, we still don't know that. Yeah.
Okay, fine. Okay. What drugs can you take after the vaccination, Dr. Edwards?
I mean, so
what drugs can
when I got my vaccine, I got my vaccine, I got some aches and pains, so I took paracetamol, and as I said, the aches and pains went within a couple of hours, and I was fine. So, I mean, I'd recommend people if they get a headache or or get some aches and pains, they can take paracetamol. Anything more severe, I think they should check with their healthcare provider. So if they get severe headaches or abdominal pains, check with the healthcare provider to make sure everything is okay. But if you just get minor headaches and aches and pains, paracetamol is fine.
Okay. So are there any drugs that you cannot take after taking the vaccine that are contraindicated?
Well, I guess steroids, immunosuppressants.
Okay. Right.
Am I answering that?
After? Yes, please.
Am I answering? All right, yes.
Yes,
So
yes.
I would say what the vaccine does is that it boosts the immune system. So you don't want to take any drugs that would impair the activity of the immune system. So, for example, you would want to wait a couple weeks, 2 or 3 weeks, before you take something like prednisolone if you have to take it. But of course, again, you have to weigh the benefits. If it's life-threatening, of course, you take your prednisolone. But what I'm saying is that in order to get the best from the vaccine, you don't want to take anything that impairs the immune system at that stage. Thank you.
Okay. Okay, I am looking at the next question. It is related to if somebody age 73 years old is on blood thinners and for clots, can they still take the Astrazeneca vaccine? Similar question, Professor Simongal.
Yes, okay. So blood thinners for clots, that's not a contraindication to the vaccine at all. It's just a very minor injection. We don't expect any bleeding into the muscle from it, but they should tell the nurses at the time that they are doing that they are on blood thinners. They must declare it, firstly. And secondly, I can't see that interferes with the activity of the vaccine either. So my opinion would be that is quite safe. Thank you.
Okay, okay, what is the science to support a link with cases spreading as a result of persons being on beaches and restaurants and bars? Is there evidence to suggest that the increase in cases and the number of deaths originated in those places? So who would like to answer that? So the person is questioning whether, I mean, the methods of spread.
Could I take this?
Yes. Yes, please.
So this virus is spread through, and it's in this order. If you really want to spread it very effectively, shouting, singing, or speaking. So think about where it has spread the most. The most prevalent spread has been noted in nightclubs. So, and it is because in a nightclub is a situation, there's a lot of loud music, and you walk right up to someone's face this far away and you shout in their face because you're trying to communicate. And when you look at these outbreaks at funerals and in churches and in choir sessions, it's because people are singing and you're projecting more droplets as you sing, and you're usually inside. And then also when you look at the professions of people who are at risk, you'll find that people in the building professions are at risk. That is because, again, building places are very noisy. You know, there's cars sort of backing up and people hammering and banging. And again, you know, you have a tendency to go into someone's space and shout at them. And when you look at again, very noisy environment in the meat cutting processing plants, we've had lots of outbreaks. Same thing again, people packed in together and they're having to shout to communicate because they're very noisy places. And so, you know, it is these environments which are the highest risk. They're usually indoors, enclosed, noisy, where, you know, you're either shouting, singing, or speaking. And then, of course, the call centers, we all know in Jamaica, classic case, you know, you've got hundreds of people who are sitting next to each other in booths talking all day long. And, you know, this is what spreads the virus.
Great, thanks. There's a question that just came in from UETV. Have any of the so-called vaccines been fully approved by CDC?
CDC doesn't approve vaccines. CDC does not approve vaccines.
It's FDA, right? Yes, fine. Right. Okay.
And that's
yes.
No, I was just saying, and that is in the US. We have to look at our own situation here in the Caribbean and who we listen to. Right.
Okay.
Which goes back to the credibility of the information.
In our case, it's WHO and FAO.
Yes.
That guides it, yes. And of course, we have been getting guidance from the WHO in terms of which
All the
vaccines we use.
All
Okay, great, thanks. All right, I'm looking at the last question. I mean, we want to wrap up by 7:45. What is your prediction for the most likely date for the achievement of herd immunity in Trinidad and Tobago? I guess the Caribbean is, by extension, given the current rates and metrics. This is from Facebook UETV. Prediction as to the most likely date for the achievement of herd immunity. Yeah, the current rate.
I think we should ask our public health expert that one. That should be Jeffrey.
Yes.
For herd immunity, we'd expect probably 70 to 80% of the population is vaccinated, and vaccines are in very short supply. So, I mean, it's difficult to, pin down a date on this. Once the vaccines become ramped up and they're more evenly distributed, then, hopefully people can achieve herd immunity. But we have to try and get 70 to 80% of the population vaccinated to achieve herd immunity, and then, we can probably feel a bit more comforted, like what is happening in the UK now. So don't know the answer to that.
Yes, yes. Anyone would like to speculate the rate things are going now? When do you see us really getting to that point?
Well, I would say that. Yeah, sorry, Christine. Yeah, no, I would
Professor
say
Carrington?
I agree with what Dr. Russell said. And I would just add that the rate at which we arrive there, when we reach the stage where we have enough vaccines around and it's things, as he said, the distribution has evened out, the rate at which we arrive there will depend entirely on the public. Okay, so not entirely, but you will play a great part in this. It is you, the public, who have to get up and go and get that vaccine to help us to achieve herd immunity. Can't tell you when, but...
So I would say something. I would want to add something here, Donald. There was an article in The Economist looking at countries, and our country was, or the group in which we were, they felt we wouldn't be completely vaccinated until early January 2024. I think that's a sort of a worst case scenario, because I was very impressed when I went to a meeting of the Caribbean, Central American, and Latin American countries last week, in which I see that vaccine development is occurring in Brazil, Chile, and Mexico. So one of the issues we have is that we're not producing our own vaccines, and the places where the vaccines are being produced, as you would expect, are keeping the vaccines for their own population. And once that's satisfied, such as the United States have recently said that they would send away some of the vaccines that they have because their population is now pretty well immunized. So that's probably a worst case scenario, and probably we will complete our vaccination drive earlier if these other vaccines come on stream, and of course, if they are accepted by the regulatory bodies. Thanks, Donald.
Okay, thanks. I'm not sure if Professor Lannis has any comments. January 2024 is a far way away.
I think that's a pessimistic scenario. The thing that's been quite interesting in the Caribbean is that when we do get our vaccines, we actually vaccinate very quickly. So it really is a vaccine supply question. And, if you look at Barbados, which I think Barbados and Antigua, in terms of proportion of the population, have had the highest vaccination rates, you see very long lines outside the vaccination centers. People really want to get vaccinated. And, the experience generally has been that the discussion when you don't have vaccines is all about the speculation about the safety, the efficacy, the conspiracies, etc. And then when the vaccine's here, it's all about where can I get it? How can I get it? And so, I am more optimistic. Once we solve the supply problem, I think the Caribbean countries can vaccinate very quickly.
Okay, great, thanks. I'm not sure if Dr. Esnad would like to comment, because the supply is one important aspect, but of course hesitancy is also, something to consider. I'm not sure where we are. Just to note, of course, that that Johns Hopkins had done a couple surveys, which they found that the level of hesitancy is actually increasing from, I think they did a survey back in July last year, and then another one in December. We did one here as well, and the numbers are not going down in terms of the rate of vaccine hesitancy. So it is possible, of course, that the first 50% of the population, would be the ones who are keen and willing to go, but after that could be some level of resistance. So I'm not sure if Dr. Esnat has any views on that.
Professor Simeon, I do agree that supply is a significant part of it, because we for sure know and are aware that there's some reservation about from more developed countries about whether they would send and distribute or prioritize their own citizens. But there's also the other part of it. While we have supply, we have the demand issue, and demand is influenced in a very significant way in terms of people's beliefs and their values and their own understandings as it relates to the vaccine. And I think that the issue of hesitancy is a critical one. And we must, as healthcare professionals and researchers and academics and the like, take responsibility and actively engage in public health sensitization that reaches out to the public and really not in a way force or enforce vaccination, but really to do what we are doing right here and right now, which is to share critical information that they could use and consciously make decisions about the uptake of the vaccine, so that vaccine hesitancy is an issue, and having the vaccine in the country will not be necessarily enough to get the vaccine uptake that we would like at this particular point. So I do agree that supply is an issue, but we have to bridge that gap as healthcare professionals between the supply and the demand, and the willingness more specifically to take those vaccines, so that we must address in very meaningful ways the hesitancy among people and understand that it is real and that those must be addressed frontally, so that people would move from vaccine hesitancy to vaccine uptake. And when that is done, then we could make maybe a bit better predictions about when we could have full uptake of the vaccine. But for now, I think this is a very difficult question to answer. But a lot of it depends on the people. And when there is medicine, the people component must not be ignored.
Okay, thanks very much, Dr. Esnat. Dr. Edwards, any final words, any messages you would like to give to the population as we sign off this town hall meeting?
So I'd like everybody to obey the public health measures. As I said, our vaccine supply in Trinidad, we're in short supply. So in terms of social distancing, wearing the face mask, hand washing, do not congregate in large groups, because right now we seem to have a little surge of the COVID-19 infection, and we're trying to get that under control. As Professor Landis said, we have done quite a good job. So we'd like to control this surge that we have. So all we have available to us now are the public health measures. So I'd like everybody to, as I said, social distance, wear your face mask, and hand washing. That's it.
Yeah, thanks, Dr. Edwards. Professor Carrington, any final words, messages to the viewing audience?
Well, I think what I would like to emphasize is the importance of listening to reliable and trusted sources for your information. And so in addition to all the ones that were mentioned before, we mentioned CARFA, the WHO, PAHO, these types of bodies. I also want to mention that everybody in their own country, you have to, of course, pay attention to your Ministry of Health, because they will be taking the information from those reliable sources and passing it on to you. So again, the same public health measures: wear your mask, wear your mask, wear your mask, social distance, wash your hands, stay at home when you're not well, etc. Okay, that's it.
Okay, thanks, Professor Carrington. Dr. Esnat, any final words?
Add to Professor Carrington's statement: trust in reliable and credible sources of information, and we listed those. I want to also ask that we remain media literate, be critical of the media, especially social media. And lastly, I think it's imperative that we look at public sensitization and partner with communities, religious leaders, and influencers even in getting the message across. But just as we have those narratives in social media, we also need the counter narratives from professionals like yourselves and healthcare workers to really reverse some of the impact of the false and misinformation and the myths that are perpetuating in the space at this particular point in time.
Okay. Thanks very much, Dr. Esnad. Professor Landis, any final words, messages to the viewers?
My final word, please take the vaccine when it's available. In countries where the vaccines have been rolled out, vaccine hesitancy actually dissipates because people can see in front of their eyes the effect of the vaccine. And don't be despondent. If people think, if we don't reach herd immunity, it's all or nothing. That's not the case. Every % that you increase the vaccination rate in your population actually does curb the virus and gradually will bring it under control.
Thanks very much, Professor Landis. Professor Simongal, any final words, messages to the viewers?
Okay, just to underline what my colleagues have said, and also to just say that the complications are very rare. If you balance them against complications that occur from the disease or death from the disease, the risk-benefit ratio tremendously favors the vaccine. So I'm advising everyone, when you are given the opportunity, go ahead and get your vaccine. Thank you.
Yes, thank you very much, Professor Simongal. So in closing, I would like to just summarize that there is scientific evidence that vaccination will result in a reduction in mortality and severe disease, as well as a number of new infections. It is also our best and safest chance to get back our lives. I don't have to repeat, what you already know about the impact of the pandemic on the economies and social life in the Caribbean, job losses, closure of schools, as well as the portion of religious and cultural events, closing of our borders, we cannot travel overseas. Importantly, based on our last hour and a half, almost 2 hours, I'm really hoping that we were able to answer the questions that you have and that you can make a more informed decision regarding, whether or not you will be taking the vaccines. Before I close, though, I must also thank a number of persons and institutions who made this evening a success. Of course, the panelists, for taking your time off your very busy schedule to field the questions from the viewing audience. There's a planning committee, hardworking, that comprised colleagues from the Faculty of Medical Sciences and Marketing and Communication Department at St. Augustine campus for planning, this meeting, this town hall meeting, as well as managing the question and answer session. I talk about Dr. Carla Maria Alexander, Kershel Barker, Nikisha Headley, Gillian Hunt, Marsha Ivy, Wendy Maynard, and Dr. Arlene Williams. Of course, UWTV, the professionals there for your expert hosting of the town hall meeting. I also like to recognize Dexter Superville for recording the questions that were played in the first session, and the UWI St. Augustine Committee on Vaccine Hesitancy and Acceptance for preparing the report that set the tone for this town hall meeting. Digicel, must be thanked for the loan of a mobile phone that was used in the question and answer session. And of course, finally, the audience for your searching questions. Finally, I advise that you always seek information, as was said before, from approved sources. And remember the 3 W's. Even though you are vaccinated, you should still wear a mask, wash your hands, and watch your distance. Have a good night, everyone.